My journey on this road is probably not too dissimilar from a number of people in this room. And it's a journey I hope that a number of folks will be sparked to embark upon. This is where I was about 7 or 8 or 9 years ago when I thought about babies with trisomy. This is what I was raised with in medical school. That these are babies who don't survive, that these are babies who have fatal anomalies, lethal anomalies, and these were the pictures I was shown. And we were doing these families a great favor, by the way, in terms of just trying to expedite the demise of their babies. We were shown graphs like this, and this is from a classic article back in Pediatrics, not that old, but the data is old. Rasmussen et al. Looking at survivals for babies with trisomy 13 and 18, and it looks fairly dismal. As you look out across those curves. We're going to talk about some other data today, though, that maybe might help you think a little bit differently about this. My journey on this trail starts back in 2009 with another person in this room, Barb Farlow. And Barb is a little bit off to the left there with a picture of her daughter, Annie. I'm in the back there with my daughter, Shay, who is trisomy 21. And we were invited up to a press conference up in Washington, D.C. And we were going to talk about the impact of nationalized health care, Obamacare, on children with special needs. And what we all perceived was going to be a tremendous impact. And it was not going to be a good impact. And having lived through that, those predictions were true. It has not been good. What we did at that conference was talk about what the potential problems would be for all this. And I have to tell you, I had my eyes opened at that meeting. I had never really talked to or met families whose children had trisomy 13 or 18, never mind survived or lived. And there were a number of those folks at this meeting. And it was an epiphany for me. I had already started on this journey a little bit, I think, because you can see my daughter Shay up there with Down syndrome. You know, after your child's been alive for 2 weeks and you're going to see the pediatrician at your medical center in San Diego, and one of your colleagues walks up to you and you tell them the story about your daughter, and they say, well, Marty, didn't you have the test? I realize that we're in a lot of trouble, that someone could actually walk up and say that to me. So I was inspired by these folks, and I think we owe them I owe them a great debt of service and a great debt of gratitude. I started looking at the data because I talked about Barb's daughter, Annie. I met a number of other families who had had children who had had trisomy 13 and 18. I'm like, why have I never heard about any of these babies? I thought they all died within the first day or the first week. How possibly could any of them be surviving? And this is some of the old data that I started to find that is out there. Now, I'll talk about the problems with data. All data, when you start looking at trisomy 13 and 18 babies, has got its flaws, and they're different flaws. But this is just kind of fascinating to look at when you look at this study that was data that was from a fair bit back in the 60s, looking at survivals for trisomy 18, that you're sitting with numbers that are somewhere around 31%, 22% when you start getting fairly far out, heading towards a year. And similarly for trisomy 13, numbers are a little bit lower, but you're talking about 13%, 29% when you're looking at that 6 month to 1 year and above window. I thought that just couldn't be possible. I've never seen these children. Now, the fact is there aren't that many babies with trisomy 13 and 18 born, but I had never come across in my pediatric clinic, working as a general pediatrician, never cared for any of these children, and I started to wonder why. Then I came across this article from Beatty et al., this is John Carey's work, looking at a soft sample. So this is a little bit biased. Soft obviously has a bunch of folks who are engaged with their families, and they've done everything they could for their families and their children. But those survivals, when you start getting out to 1 year, are 40%. I'm like, and we're calling this fatal and lethal? What is wrong with us? So I said there's problems with the data, and there's problems with all this data, and I think we have to be very open, transparent, and cognizant about that when we're looking at studies related to trisomy 13 and 18. All of the data suffers from the fact that these are relatively rare types of conditions. So when you're looking at single center studies, the numbers are relatively small. So it's a little bit hard to know actually what to make of survival numbers per se from individual centers. Large studies, when you look at big registry data and pool it, are really not able to dig into the actual records very well and determine what kind of care was actually offered. And this is a huge bugaboo for me, is if you're talking about aggressive versus non-aggressive treatment, what does that really mean and what was really offered? And is non-aggressive treatment providing feedings and G-tube feedings, or is non-aggressive treatment, we don't feed the baby at all and we're offering palliative care, which for some families may be perfectly wonderful. But we just don't have a real good sense of what kind of interventions are being offered at that point. When you start talking about big studies with lots of babies, the registry data especially, as it's hard to get into the records, also hard to know if you're including mosaics in those groups. They're a small percentage of the infants with trisomy. Maybe people estimate somewhere around 1 or 2%, but I mean, it counts. And we do know that the trisomy mosaic infants and children do seem to do a fair bit better. So it's important to recognize that. Then people say, well, in the old studies, Marty, you know, in those old studies, I mean, they didn't even have diagnosis, so a lot of the babies had already died. And I say, yeah, well, in the old studies, you know, a lot of the babies they didn't know had it, so they took care of them and they lived. So I think it works both ways. In the new studies, there may be increased numbers of terminations for more severely affected babies, so we're seeing higher survival rates. And that may well be true. That's very possible. But when interventions are described, as I said, no one really gives detail about what those interventions are. There is no publication that I have been able to find anywhere that talks about what survival is, separating out babies who are just offered palliative care or no intervention. So I don't think we know the natural history very well of this disorder is the bottom line. So in the current era, there is a good study and it's reasonably current era, that just came out. And this was published back in December in the American Journal of Medical Genetics. It's from Bob Meyer et al. And this is a large US study looking at 9 states and looking at survivals for trisomy 13 and 18 babies. It's the largest cohort of survivors for trisomy 13 and 18 that there is in the literature. And it's 693 infants with trisomy 13, over 1,100 babies with trisomy 18. It's over a fairly big spectrum, 1999 to 2007. It includes everything, so it does include mosaics. We're not able to separate out mosaics. And it also may suffer from some of the difficulties we have with US data in terms of death certificates. Because states report deaths, we don't have a national death registry that most states use, although one state in this study did, which is important, and it's Georgia. Georgia participates in the National Death Index. So when Georgia looks at how well did their babies do in terms of survival, they have pretty good numbers. So this is Meyer's data. And if you look across the bottom there, this is for trisomy 13 and 18. Trisomy 18 is blue, for those of you who can't see it, and trisomy 13 is in green. And we start with point survival 1 day, 1 week, 28 days, 1 year, 5 years. And what is interesting to look at is survival at 1 week sits somewhere around 45 to 50% in this large registry database. But then when you start to get out to survival at 28 days in 1 year, you see the usual decrement that we see in terms of survival for these babies. At 28 days, you see survivals that are down around 35 to 40%, and then survivals at 1 year are sitting somewhere around 10 to 15%. What I find fascinating, though, and I only started thinking about this after I started preparing for this meeting, is if you make it to 28 days, your chances for survival are fairly significant. Your survival rate at that point is going to be, from 28 days out to a year, somewhere around 40 to 50%, which I've just never thought about trisomy 13 and 18 babies that way. So it makes me wonder, and we could talk about this and will, what happens in that first month? There's a lot of things that go on that maybe we are losing babies that if we had partitioned the data out, we might get a better sense of what the true history for survival for these babies is. And it's a similar graph when you look further out for trisomy 13 and 18 for 5-year survivals. They plateau at the 1-year survival. So if you make it to 1 year, your 5-year survival is about the same as your 1-year survival. How many cases of lung cancer and pancreatic cancer can we say that about? Not many. So this is some other data, just looking at survivals. And there's a number of papers that you could pull out. They all suffer from the fact that they're generally small. I tried to pull out some of the intervention papers, again, small, probably with some biases built in there. But it drives home the fact that some of these babies with interventions will survive for periods of up to a year or more. And it comes back then to what do you define as fatal or lethal if someone is living after a year of their diagnosis. This is from Japan, where there's been lots of work that's been done in terms of intensive care, whether it's intensive care, including respiratory care, or it's cardiac care, including cardiac surgeries. And survivals start to head out towards about 25% in this series of babies, which is 26 infants. These were all babies who are fairly sick, who required intervention, and at least respiratory support, a good number that required cardiac support, and some that received cardiac surgery. This is a group of cardiac surgery patients with trisomy 13 and 18 from Japan as well. There's a couple of papers from the States now that are reporting somewhat similar results. I didn't want to take up your time with all these smaller studies. But if you look at the epochs up here for these babies, small, A, B, and C, A is 2000, 2002, B is 2002 to 3, C is 2003 to 5, 13, 9 to 9 babies. But what you can see in Epoch C, where palliative cardiac surgery was done, no intraoperative cardiac repairs, no intracardiac repairs. So this was mainly PDA bands that were performed. Survivals for those babies head towards 50%. So this is, over the last 3 or 4 years, just shocking data to me. Now we all worry about, well, that's all great, the survival thing and everything. I think the unspoken undercurrent that really runs through this whole discussion is what happens developmentally with these babies who are severely delayed, cognitively impaired, mentally retarded, and you can run the list. And the fact is they are delayed. This is from John Carey. John looked back at a number of babies through a large registry and looked at their developmental quotients at 1 to 3 years, 3 to 5 years. And what you do see is some sense of advancement in their developmental abilities, but they do seem to plateau out. And plateau out somewhere, depending on the disorder, somewhere between 6 and 8 to 9 months. So absolutely there's severe cognitive delay that's associated with this, and no one would take issue with that. What I think is really interesting, though, is when you go back to that Meyer article, which I think is fascinating because you see survivals that plateau at 1 to 5 years. You see survivals that really look pretty interesting if you can make it to 1 month. And then you survive out to 1 year, 50% survivals. But if you break that data out by state, what does the variation look like? And this is it. So these are the states that were engaged in that project. I think I got part of it cut off, so I apologize for that. But you'll get the gist of it here. And you can see the numbers of babies in each of these cohorts from each of these states. But what you can see is the variation for survivals in trisomy 13 at 1 year and 1 month. And you look at a place like Georgia, and I'll tell you the one in the middle that doesn't have the recognition on it in there is, that one is Florida. And then you look down the road at New Jersey, and you see much higher survivals for trisomy 13 babies than you see in many of the other states. And why does that variation exist? I think we have to ask ourselves that question. I don't have an answer, nor did the authors of this publication. But this is tremendous variation. No one would sit generally and say the survival at a year for a baby with trisomy 13 is going to be 20 to 25%. That's not typically what we're thinking about. But in Georgia, it kind of looks like that's the way it is. Trisomy 18, similar. So very wide variation in what we see for survivals. And again, if you're in Georgia, if you're in Massachusetts, you see much higher numbers for survivals. And no one has an answer. I think this is going to be data that's going to be very interesting to dig on and try and understand what is going on differently in those environments. And you see this kind of variation within the states in the United States. I have no doubt that we would see that same kind of variation across hospitals if we could ever get enough numbers to make it look significant and say anything worthwhile scientifically. So it is a fact that more of these babies are living. You've seen the data that says that these babies are surviving at rates of 10 to 15 to 20 to 25%, depending where they're born and where they live, out to a year. And they are out there using services. So they are being admitted to hospitals. You can see this is United States data from the kids database. This is what we call our hiccups database, which looks at procedural codes and discharge diagnoses in hospitals across the country, across the US. And what you can see on this graph for trisomy 13, 18 lumped together, based in years of the patient, is 1 year all the way out to 18 years. And you can see for 1997 and 2009, what is happening in terms of service utilization for inpatient hospitalizations. And there's been a markedly significant increase in what we're seeing for services being used. And these run the gamut from surgeries for G-tubes to cardiac repairs to tracheostomies, a whole host of different services, including admissions for acute illnesses where someone might come in and need fluids or that type of thing. One of the things people have said is, well, surely, probably this is just a handful of kids repeatedly using the same services. And the authors of this publication feel that is absolutely not possible, given the spread of the ages and the consistency and the smoothness of the curves over time. So we are using a lot of medical services, and these babies are out there, and we just haven't really, as a uniform group, as pediatricians, neonatologists, as medical providers, heard about them. In this database, 46% of trisomy 13 and 18 patients were discharged alive after a mean of 7.8 days. So that's a huge number of babies, and that should really prompt folks who say that these babies don't survive to be born, or if they do survive to be born, die immediately, to really second think what they're actually saying in that context. This is the data. So it makes me think, as a neonatologist, why are we like this? It makes me a little bit angry, actually. Because I work with babies all day long who live on the edge of survival. I work with 24-week babies, and my goodness, no matter what we do, we haven't had a great advance, honestly, come along in about 20 or 30 years other than antenatal steroid administration that really has made a huge market impact in survival of these babies. And we don't even do antenatal steroids very well. So if my rate for survival for babies at 24 weeks with severe morbidity, including severe IVH, infants who may have severe necrotizing enterocolitis, they've had surgery, they have a colostomy, they have short bowel, they have retinopathy of prematurity, they've got blindness. If my rate for discharge for those babies at 24 weeks is sitting around 5 to 10%, how come I don't sit and tell a parent with a 24-week baby that you've got a baby with a lethal malformation, or you have a baby with a fatal flaw that is not survivable? I don't do that. Why don't we do that? Leave it to you to think about that. It bothers me a lot, though. And this is back to Dr. McGinnis's comments earlier. This is from UK cancer research. So if we've got lung and pancreatic cancer survivals that are sitting at a year at about 20 to 30%, not too different from the numbers I've showed you for trisomy 13 and 18, why don't we tell these people they have a lethal problem and abandon them? We don't do that. Look at these 5-year survivals for these different cancers. You've got 4 cancers on there. Oh, and you might say, well, some of the cancers are different than other cancers. And I would say, you're right. And I hope one of the things that you get at the end of the day is if you've seen one trisomy 13 or one trisomy 18, you've seen one trisomy 13 or one trisomy 18. They are all different. You cannot lump them together. So how do we get to this place? And how is it that we've put parents and families in this place? Well, there is good literature on this that talks about and has really tried to sketch out how we as medical providers think about this. And I think we bear a huge brunt of the current dealings that we have with people and families with trisomy 13 and 18. I think we as medical providers are responsible for this in large part. So when you survey folks and you look at obstetricians, and this was done by Wilkinson pretty recently, this is UK, Australia, and New Zealand, looking at attitudes about trisomy 18 and survey them, 84% say it's lethal. Well, that's interesting because only 54% say it's incompatible with life. And then should they be resuscitated at birth, only 44% agree that they should absolutely not be resuscitated at birth. So this is confusing to me, and I think it suggests that there's confusion on the part even of some obstetricians about how they think about this and the terminology that we use. And I think it goes to the point of we have to be very careful about words and very careful about language, because the language and the words that we use colors everything, and it colors how we provide care. This is looking at survivals and talking to those same obstetricians for that same study. And if you ask them, do you think that a child will be live born and live and be alive at a week, only about 25% said that 50% would be alive. The vast majority thought that they would not be alive at a week. So it's back to that sort of, I really think it is from the data, it is a misconception. Most of these babies, if we provide probably some basic care based on the data, will be alive. Nearly 50% will be alive at a week. So what about neonatologists? I mean, my crew is not innocent in this either. I don't want to just pick on obstetricians here. I mean, I'm here to beat up on neonatologists as well. And so this was a survey that was done by Perlman. Jeff sent this survey out. This is a while back in 2008, proposing a sample case of a baby with trisomy with a heart defect. Not classified, not talked about what the heart defect was, which I think the premise of that question is problematic in and of itself. Because I think if we're being reasonable and you're talking about a baby with trisomy 18, plus you throw on top of that complex heart disease, you're in a very different place than you are with a baby who might have a small VSD, or even maybe a VSD that requires banding at some later point if you don't want to do a full repair. Those are very different patients. Nevertheless, he asked the question, and he said, how many would initiate resuscitation? 44% said yes, 56% said no. And then he asked, well, why would you not or would initiate resuscitation? The vast majority said that they would only initiate resuscitation due to maternal request. And then this got broken up a little bit, but the minority said that they would do it because they thought that babies might survive or had a chance for survival, and they wanted to assess the babies after they were born and see how things went. So what is really fascinating about this study is not so much the data per se. I don't think anyone's really shocked at that necessarily, that most of my colleagues would say we wouldn't resuscitate a baby with trisomy 18 given a reasonable choice. What is shocking is actually the article and the way it's written. And the whole article, to me, is actually a little bit offensive. Because what Jeff goes on to say is that we, based on this data, we, being the collective we as neonatologists, have abandoned our principles and are now acceding to parents' desire to have everything done and abdicating our responsibility to the welfare of the baby, which, follow on, he never quite says, we should offer palliative care, which would be great, or allow them to die and offer no intervention, because this is fatal. He uses fatal or lethal about 5 or 6 times in the article. And then what about those of us working on the front lines? So this is nurses, and this is trainees. So where you see peds and OB, those are residents. Those are trainees. Those are not staff people. And you can see DR nurses, NICU nurses, and actual children's hospital nurses, referral center nurses versus peds nurses, and what they think about different types of disorders when the question is posed, would you terminate your pregnancy? And these are the answers, the percentages. So when you look at trisomy 18, 75% in terms of obstetrical residents and 74% of peds residents would terminate that pregnancy. So there clearly is a personal belief on the part of certainly in the US, some of the providers there, that they have clear ideas about what they would do with this type of a pregnancy, and I have no doubt it has to spill over into how we provide care. Equally disturbing to me, as a pediatrician, as a neonatologist, and a father of a child with Down syndrome, is that 73% of obstetricians would terminate Down syndrome. So I said that I think this spills over into how we deal with patients, and I just want to give you some anecdotal evidence of that. And I want to go back to language. And I want to talk about the language which we use to pressure parents to terminate and to pressure parents not to resuscitate or intervene in a really active way for their babies. And mind you, I'm not saying that we should intubate and do surgeries on every baby, but I'm talking about just opening up the possibility for basic care, things like feeding tubes, or maybe a G-tube, or other things that might be available to other babies, like that 24-week baby that I told you about, that we are not thinking. It's not even crossing our minds to make it available to these patients. And then on the newborn side, a GYN asked me if I had any children, and I told him I had a daughter, about 9 months old at the time, with full T18. "Oh," he said with a sad face, "so you're just like counting down the days." I was told by a neo no one with trisomy 18 had ever survived. I've heard this repeatedly from folks. They have been told no one has ever survived, or there's one baby who survived. We found out about T18 days before we left for a trip to Africa. We were told it doesn't matter where you give birth. The outcome will be the same for the baby, whether in an elite hospital or the African bush. So the question for me, and what you all have forced me to do with this conference, is really think about this. Why are we like this as medical providers? Why do we talk to our families this way? Why have we not been transparent? Why do we give them misinformation? And I think there's a few reasons. I don't think it's all of the reasons, but I've got them listed up here. I think my excuse earlier on was that's the way I was trained. It's the only thing I knew. I didn't mean anything bad. I mean, I didn't want to hurt. I mean, I thought I was doing a good thing. I mean, they all died. I mean, I wanted to spare families pain. I thought it was the right thing. And that's what I was taught. Many of us haven't, many of us hadn't seen a child with trisomy survive. How could this actually be possible? That article's crazy. Small center, how could any, even 10%, 15%, that's not really lethal. But I've never even seen 1%. So, how can that even be? I think for some folks there are other sorts of elements that feed into this, though. I think for some, what they think is that mental disabilities and suffering equate with each other. And so if you're disabled or mentally impaired or cognitively delayed, it absolutely equals suffering. And that is where they work from. And so they believe that to bring a child into this world who's going to be severely impaired and delayed, it's going to be a life of intense suffering. And they feel that they're doing the right thing. I think they honestly believe that. I think what they don't know is the unbelievable joy that these children bring into our homes. And I don't think they understand that these children are more perfect than they will ever be. And I don't think they understand that normal is a cycle in a laundry machine. It does not describe people. I don't think they get that. I think some are pretty paternalistic. I think some, they feel that way, it's well-intentioned, but they become very ingrained in that belief, and it almost becomes vehement. I don't want to say violent, but when you talk with families who are trying to get some care for their child, physicians, some of us dig our heels in, and we just will not allow it. It is a bridge too far. And I don't know how to break that down. So I think words mean everything. Language means everything. And what we have to realize at the end of the day is what we're fighting for is these wonderful, beautiful children who may have very short, limited lives. They may only be a day or two. They may be longer, but they are valuable lives. And to call them incompatible with life, fatal fetal anomalies, to say they're lethal, totally diminishes their personhood, the value that these children have to offer us. And what's even sadder is we just don't see what they have brought to us. The fact that we use this language and can't see it really is more of a commentary on us than it is a commentary on them. I think a better language to use is life-limiting. It's certainly life-limiting. And we can't promise that these children are going to be 5 and 10 and 15 years old and walking. They're going to be severely delayed. They're going to have problems. But we should have fully informed families that can make these decisions. I think what's ultimately underlying all of this is not so much, in some ways, the real feeling that the baby's going to die immediately, because I think it's creeping out. People are starting to understand they survive a little bit. but it's more really a comment on the quality of life issues. I think it really more refers to the fact that some people really feel severely impaired, incapable children or adults or folks that we don't necessarily need or want at this point, because they're a burden on the families, and it may all be very well intended to try and support the families. But at the end of the day, I think that really needs to be a decision for families to make. So what we currently have is pretty common medical management, I think, in a lot of places for trisomy 13 and 18, though there's pockets of us in this room and around the world that are trying to do things better. What ultimately happens, though, when you treat all trisomy 13s and all 18s the same, is that you box them into a diagnosis that is lethal, and lethality begets lethality. When something is lethal, tagged as lethal, we treat it as lethal, it will become lethal. We have that power and that ability. And the fact is that a baby with trisomy 18 who has no cardiac defect, who maybe can't eat but needs a tube to feed, vice a baby with a diaphragmatic hernia, those are two very different babies. And none of us, I don't think in this room, would say that those are the same. We need to look at these babies as individuals and realize just as broad cancer statistics don't represent what goes on with individual patients, nor do survival statistics or branding diagnoses as lethal. So I think the one thing to keep in mind as you're walking down the road when you leave here and you're looking at data and you're thinking about practice is the notion of the self-fulfilling prophecy. It has come to light and is blazing with trisomy 13 and trisomy 18. And what the self-fulfilling prophecy says is that a false description of a circumstance evokes behaviors that make the original false conception come true. So the specious validity of the self-fulfilling prophecy perpetuates a reign of error. And it's a lot worse than a reign of error in this case. It perpetuates a reign of early death. So infants with a prenatal diagnosis have a variety of different needs. And what we often do in discussing these cases in publications is talk about aggressive versus non-aggressive intervention. And the challenge with that is when we have babies in these studies, many of whom are postnatally diagnosed, what will happen is when that diagnosis comes in, it's not known prenatally, care will be oftentimes withdrawn. There are not any studies, just as there are none that really separate out the babies who just got pure palliative care. There are no studies that really separate out, including a study from my own institution published by one of my colleagues, that separate out, okay, what happens when a baby is diagnosed? Did we withdraw care? Those babies get lumped into aggressive care because they may have been on a ventilator, they may have been getting IV fluids, and then they got a diagnosis and care was withdrawn, and so they die. And so when you withdraw life support, babies are going to die when they're critically ill at that point. And that's not well separated out in the literature. At the end of the day, this is where we end up with parents on the trisomy journey. I think it's a horrible place to be right now. It's, you have just a difficult, challenging pregnancy experience, which has been torn asunder. And then you're dealing with very, very difficult interactions on the other side with a variety of folks, from healthcare providers to family members who don't understand, who are reading different literature. It's very, very difficult. And it's one that leaves you in many ways as a couple or as a mom utterly alone and isolated because there just isn't help. And there's no one that's willing to really talk and be open about what the possible potential is and talk generally in language other than lethal and fatal. And this is, I think, what the people in this room have to leave and really start to try and change. So my work over the last 5-6 years has really been in supporting and consulting with families around the world with trisomy diagnoses and other difficult, challenging prenatal diagnoses. I pick up a lot of my referrals and families from Facebook. I absolutely could make a living if somehow I could get paid sitting on Facebook as a consultant to families with trisomy 13 and 18 who cannot find people who will give them reasonable medical advice. There's absolutely no doubt. I've had to add an international calling plan in my phone because after the first month or two of doing this, it became clear that this was going to be a much more involved process, and it requires a lot of time, and folks need help, and we're not giving it. So what I do when I talk with folks is try to be honest. So I talk about, after I hear initially what's going on with them, what their journey has been, what is their baby's name, congratulate them, which for many of them, they've never heard any of that, which is horrible to have to hear it from someone over the phone. I try to get a sense of what they desire for their baby. Do they want to get to a live birth? Do they hope for more after that or not? And then discuss all the issues related to those things. I try to talk about the value of a life-limited diagnosis, and I try to offer hope when there's hope for survival. I think there's always hope for the babies. They may only live 2 or 3 or 4 days. There's huge hope and huge beauty, and there can be incredible love there if we would just make it clear to folks that that exists. But when there's hope for actual medical care, I will talk to them about that as well. The challenge is sometimes trying to make that care available and getting people to places where it can be received. So even in the States, we struggle with this. There are certain places and facilities that we know are more trisomy friendly than others. I think there is lots of opportunity for work in this area. Trisomy 13 and 18, I said earlier, I don't think we know the natural history of children with this disorder and the width and the breadth of this disorder. We don't know it because we haven't been interested in studying it. We've been so busy putting them in a box that says lethal or fatal fetal anomalies that we just quite honestly don't know the history and what they're capable of. There's lots of opportunity for study here, and I've talked and am talking with a number of colleagues about this. But in terms of delivery plan, mode of delivery, there's conversation about this all the time, C-section versus vaginal delivery. Use of antenatal steroids in babies with trisomy, certainly if they're preterm, which by the way, a lot of obstetricians will deliver their preterm baby with trisomy and not deliver steroids, which would be indicated in other babies. Is palliative care, is that the intervention that is needed? And you're going to hear from some unbelievable folks who are doing incredible work with palliative care. And how can we make palliative care better and more available to folks who desire that route? And that's probably the preferable route for their baby, given some of the problems that they may have. When there's uncertainty about the possibility for the baby and parents aren't sure what they do, I will say I tell them to consider the possibility of supporting your baby. So if they say my baby has trisomy 18, they weren't sure what they saw in the ultrasound, if there's a heart defect or not, we'd like to go ahead and keep our baby alive. I say, well, stabilize your baby, and then we will go ahead and we can assess the baby thereafter. That is possible, and that is doable. So I hope where I've gone is from this guy, who this is really all he could think about with trisomy 13 and 18, and gone to a very different place. I think these are the people with trisomy 13 and 18 that we should have pictures of. And we just don't. These aren't in the books. I mean, these are all trisomy 13 and 18 babies who lived for over 3 months, a variety of ages here. I think I've alluded to the challenges that we face with these babies and things that we need to consider in terms of study. The one thing I will bring up is central apnea, which we attribute to a lot of these babies, is I'm not so sure that they all have central apnea. And we've called it that since the 60s without really documenting it and really studying it. Is it an airway issue? Is it obstructive apnea? Is it seizures? This is something that's starting to break into the literature a little bit now. And then just trying to study care that might be best for these babies. These lives are worth living. Barb is 37 years old with trisomy. Matthew was 2 days old and died with his trisomy. And I think all of these people are worthy of life. I think what we have to remember is what we do as physicians and as providers is a gift. We are blessed with a blessed profession of service. And love has to be part of that service. We don't talk about love as physicians. I would encourage us all to be talking about our young doctors, our young trainees, our young nurses, about the role of love in caring for your patients. It is an unbelievable privilege to be involved with a family like this at the most difficult time in their lives and be an invited guest. An invited guest should never be rude, and an invited guest should always respect their host. This is from Jean Vanier. who is the founder of L'Arche, which maybe many of you know, but it's a number of communities for the disabled around the world. There's 200 or so of them now, and I think these are wise words. To love someone is to show to them their beauty, their worth, and their importance. Thank you very much.
Thank you.